Hello and welcome to Best of the Day, a focus on solid tumors. I'm Dr. Ann So from MD Anderson Cancer Center, and I'm here with Dr. Ramaswamy Govindan from Washington University. Dr. Govindan, thank you so much for being here today.
Thank you for having me.
I'd like to start off to get your general impression of what's the most important and exciting things to come out of ASCO this year for lung cancer.
We see a lot of progress in immunotherapy. We've seen a drug that targets a stem cell-like antigen DLL3, delta-like ligand in small cell lung cancer. And there is a lot of impressive work going on in the world of adaptive immunotherapy, both in solid tumors and liquid malignancies. And I find that whole area very fascinating.
Mm-hmm. Was there anything in clinical practice that you think came out that should be shifted or changed for the general practitioner?
I think we're making incremental progress here, and one practical matter that I think our audience, community oncologists would find useful is results from the ECOG study, the adjuvant study 1505 that looked at chemotherapy with bevacizumab. Those the primary results were presented at the World Lung Conference several months ago. And in this meeting, we heard about the outcomes with regard to different chemotherapy regimens, and this study allowed the use of cis-pemetrexed, cisfenarelbine, cis-gemcitabine, or cis-docetaxel. My impression is that these chemotherapy drugs are similar in terms of efficacy, not the primary endpoint of the study, but interesting analysis given the large population. So it is of some use for the practicing community oncologists.
Great. Well, I want to turn our focus over now to the immunotherapies in non-small cell lung cancer. And then at the end, we'll talk about small cell, as you had mentioned earlier. But in non-small cell, with the checkpoint inhibitors, specifically, let's start with CTLA4 inhibitors. What's your general impression about their use?
Ipilimumab or CTLA4 targeted drugs by themselves are not active in lung cancer. We also learned that in combination with chemotherapy, ipilimumab does not really add much to the outcome. So by themselves, they may not be of much use in non-small cell lung cancer. However, in combination with PD-L1 inhibitors, that's turning out to be an interesting area. We have known that PD-L1 inhibitors, along with CTLA4 inhibitor combination, is very effective in metastatic melanoma, and we are beginning to see that kind of synergy here in lung cancer, although not to that extent. In fact, I want to mention the results of the Checkmate 012, which is a frontline study where patients with metastatic non-small cell lung cancer got the combination of nivolumab, ipilimumab, or nivolumab alone. I'm very impressed with the frontline activity of this combination. In fact, the response rates are upwards of 70%. The median progression-free survival was upwards of 8 to 9 months with the combination. And that's something we have not seen with any chemotherapy drugs. Of course, we've seen that with targeted drugs, but those targets are not present in all these patients.
So do you think immunotherapies are going to replace chemo?
I think there are two areas that we have to pay attention to. One is the combination a better strategy than chemotherapy, so we have to do those trials. More importantly, can we select patients who may benefit from the combination? And I think that there are hints emerging that the PD-L1 expression may select a group of patients who may benefit more from the combination. A small number of patients, but in the Checkmate 012 study, it seems that if the PD-L1 high expressors over 50%, and an impressive number, if I'm not mistaken, upwards of 80-90% responded 80-90% did very well with a combination of ipilimumab, nivolumab, with a 1-year survival rate in that population, arguably a very small number, is in the range of 80-90%, which is something I've never seen with non-small cell lung cancer. Big caveat: we need to look at more patients. We need to validate this in larger studies, but it is really promising.
What about the PD-L1 inhibitors, atezolizumab, avelumab? What is your thought on those?
I think clearly, I personally don't think there is a big difference between the PD-1 and PD-L1 inhibitors. And the way it has been approved in non-small cell lung cancer, one drug, nivolumab, has been approved without any testing, pembrolizumab in combination. But I think what we need to do is how best to combine that. And I think that's where I think we will find how these drugs get approved in the future, the newer drugs like atezolizumab. And in fact, there was a presentation in the development of therapeutics pro-oral session where OX40, an agonist that boosts the immune system, the T cell activity, and suppresses the inhibitory T cell regulatory activity, actually in combination with tezolizumab was first very well tolerated, really no significant grade 3-4 side effects. And in a very small study, there have been some very nice responses in a couple of patients to begin with. But the fact that they can be combined without excessive toxicity is an encouraging thing. We got to figure out how to combine these agonists that boost the immune system with those that releases the brakes. That's the PD-L1, PD-1 inhibitors.
So what is your general impression about the different side effect profiles between all these immunotherapy agents? Is it about all the same? What's your general thought?
I think there are two different classes. CTLA4 inhibition, probably in lung cancer, produces more toxicity. That's my impression. The PD-1, PD-L1, a small number of them have significant side effects, and the combination arguably produces more side effects. Between the PD-1 and PD-L1, I've not seen much of a difference in terms of side effects. And we have to get up to speed on how to manage the immune-related side effects with prompt attention to supportive care measures, and if necessary, using drugs like infliximab for diarrhea, etc. So I think we will get better and better at that.
Okay. So let's talk a little bit about small cell, because you had mentioned a very promising agent before. In terms of ASCO, what do you think is the biggest thing to come out?
I was very impressed with Dr. Scott Antonia's presentation in the Checkmate 03 trial, which looks at nivolumab, ipilimumab plus nivolumab, and the combination once again seemed to have much higher activity, almost twice the response rate seen with nivolumab. The combination of Nivo and Ipi were looked at in a couple of different doses, and the Nivo 1 and Ipi 3 dose given every 3 weeks appeared to be very well tolerated, along with twice the number of responses and 30% 1-year survival rate or so. So I think that combination is certainly poised to move forward, in my opinion, in larger studies. And if they are confirmed, it definitely would represent one of the first options for patients with resistant small cell lung cancer in a number of years.
So can you foresee a future where we're using sequential immunotherapies in small cell?
I think so, it's possible. Small cell is not thought of as a hot tumor. It's considered to be technically a cold tumor. But I'm sure we have to find ways to make it hot and make it immunoresponsive. And I think this combination probably may do that, hopefully.
Great. Well, thank you so much for your time. And I'd like to thank the audience for joining us for Best of the Day, a focus on solid tumors, lung cancer.